Hello friends, I am a surgical resident, third year surgical resident. Today I'll be discussing something very about carcinoma gallbladder. So let's begin. Gallbladder cancer is the sixth most common malignancy of the gastrointestinal tract, accounting for 80% to 90% of the biliary tract cancers. It has a very poor prognosis and it's very common in North Indian and particularly among the women. As a result, laparoscopic cholecystectomy is done even in cases of asymptomatic gallstone in North Indian women. What are the peculiar features that make CA gallbladder an advanced disease? Actually, what the sequence of histological sequence that we get in GI tract? It's mucosa. Mucosa has three components: epithelium, lamina propria, and muscularis mucosa. Then comes the submucosa. Then comes muscularis propria, and finally fourth layer is serosa. What happens in gallbladder is lamina propria is directly followed by muscularis propria. That is, muscularis mucosa is missing and submucosa is missing. So and that muscularis propria is a high lymphatic supply, and there is also absence of cirrhosis on the liver side, which leads to early liver bed infiltration. The incidence of gallbladder cancer increases after the age of 45 years and is maximum at the age of 65 years. What are the risk factors for the development of carcinoma gallbladder? History of gallstones and acute cholecystitis, family history of gallbladder cancer, place of birth, helicobacter infection, typhoid carrier status, liver flukes like Clonorchis sinensis, obesity, use of mustard oil, high parity and high number of pregnancies, and late menarche. What are the clinical features of carcinoma gallbladder? Gallbladder carcinoma may be diagnosed preoperatively, intraoperatively at the time of surgical operations for abdominal symptoms attributable to another disease process, or postoperatively as incidental detection. Almost 50% is diagnosed as incidental gallbladder cancer. For example, if you took the patient for laparoscopic cholecystectomy in view of gallstones, and you send that excised specimen of the gallbladder of the pathology, and later it turned out to be adenocarcinoma. So that way, more than 50% of the such cases are diagnosed incidentally in the post-op phase. The typical symptoms are right upper quadrant pain or discomfort. In advanced stages, patient may present with anorexia, weight loss, jaundice, ascites, or a palpable mass. Now, what are the various investigations that is required that can be done? Blood investigations. Deranged liver function test is seen usually in locally advanced disease. Tumor markers like carcinoma, embryonic antigen, and CA19-9. CA19-9 is most commonly used, and a cutoff value more than 20 international unit per ml has sensitivity and specificity of approximately 79%. And elevated CA19-9 at the time of the diagnosis actually suggestive of very poor prognosis. And in imaging, suspicious features of gallbladder carcinoma on USG. What are the various suspicious features of gallbladder carcinoma on USG? Asymmetric wall thickening or calcification, presence of mass lesion, liver infiltration or metastasis. The sensitivity of USG in advanced stages is 84.6% and the overall accuracy is 90.5%. Computed tomography scan. CT of the abdomen is the best modality to define loco-regional extent of the disease as well as the distant metastasis. It can appear as mass protruding into the lumen or completely filling it. Focal or diffuse thickening of the gallbladder wall with enhancement. Liver infiltration, metastasis, bile duct involvement, lymphadenopathy, adjacent organ involvement, peritoneal diseases. MRCP is usually indicated if there is presence of jaundice, features of jaundice. To plan the drainage, to ascertain the level of obstruction and to plan the drainage procedure. Gallbladder cancer usually appears as hyper-iso-intense mass or wall thickening in T1 in relation to the liver, and is usually hyperintense and poorly defined in T2 sequences. Endoscopic ultrasound is also one of the newer modalities. Now, PET CT scan is used to detect occult peritoneal, mental, and lymph node metastasis with sensitivity of 56%. Biopsy and cytology. It's a very important thing whether biopsy is needed or not. If in the pre-op phase that you're very certain that if it's only indicated if we are planning for a neoadjuvant chemotherapy or a palliative therapy, that is when the tumor is unresectable and or the patient is unfit for the surgery, and we want to give we don't want to operate on the patient, then only we take percutaneous fine needle aspiration or core needle biopsy. Or if we are sure that metastasis has occurred, M1 disease has occurred, then there will be no role of surgery, or there is no such thing like palliative surgery in carcinoma gallbladder. So it's not indicated in lesions that are deemed surgically resectable on imaging. Now comes very important thing, TNM staging. It's AGCC 8th edition which is the recent edition of gallbladder carcinoma. We will study that. TX is primary tumor cannot be assessed. T0 is no evidence of primary tumor. TIS is carcinoma in situ. T1 is tumor invades lamina propria or muscular layer. I told you initially that there is no submucosa, and there is no submucosa in this muscularis mucosa, and submucosa are absent in gallbladder. So after lamina propria directly comes the muscular layer. So T1A is tumor invasion into the lamina propria, and T1B is invasion into the muscular layer. T2 is perimuscular connective tissue. T2 is further divided as T2A and T2B. T2A is infiltration on the peritoneal side, and T2B is infiltration, perimuscular connective tissue infiltration on the liver side. T3 is tumor perforates the serosa, visceral peritoneum, or directly invades liver or one of the adjacent structures like duodenum, stomach, colon, pancreas, omentum, or extrahepatic bile duct. T4 is tumor invades a main portal vein or hepatic artery, or invades two or more extrahepatic organs or structures. N1 is less than 1 to 3 regional lymph nodes are involved, and N2 is 4 or more than 4 lymph nodes are involved. M0 is no distant metastasis, and M1 is distant metastasis. Now we will consider the management. For example, you operated on a 45-year-old female who was having gallstones, and later these gallstones turned out to, and you send them. You sent this specimen to the pathologist, and she said that there is a feature suggestive of adenocarcinoma with T1A staging. Now you don't have to do anything. Simple cholecystectomy which you have done is sufficient. But if she says that there is invasion into the muscular layer also, that is, now the stage becomes T1B. Now what you have to do is you have to call the lady and do a staging laparoscopy. To look for various nodes, various metastatic sites for metastasis. And if there are no metastasis, what you will do is look for retrocaval lymph nodes. Let me explain you. This is the lymphatic drainage. From cystic pericholedocal lymph node, it goes to retroperitoneal group of lymph nodes and to posterior superior pancreaticoduodenal lymph node and inter-aortocaval and celiac and supramesenteric aortic lymph node. What you do is in staging laparoscopy, look at liver, look at omentum, peritoneal cavity. If there is features of suggestive of deposit, then it becomes a M1 disease. And you also have to take biopsy of intra-aortocaval lymph nodes and send them from HP. And if they are negative, then what you will have to do is a radical cholecystectomy. What's a radical cholecystectomy? It's R0 resection plus nodal dissection if aortocaval nodes are negative. Because if aortocaval nodes are positive, then it becomes a M1 disease. Then you don't have to do anything. You will have to take the patient on chemotherapy. In that case, there are no surgical options available. But if it's negative, you will have to do R0 resection and nodal dissection. Nodal dissection includes removal of the common hepatic artery nodules and station 12 and station 13 lymph nodes. And also ask for the cystic duct margins from your pathologist friend. If they are negative, you just have to observe. And but if the cystic duct margins are positive, then you have to revise the cystic duct margins. Or what else you can do is you can do the excision of the extrahepatic biliary duct. Now what if we have discussed T1, T2. Now what if the staging is T3 and T4? Now you have to give neoadjuvant chemotherapy followed by restaging, and then again staging laparoscopy or diagnostic laparoscopy, and then you have to take the patient for radical cholecystectomy. Radical cholecystectomy involves removal of the R0 section of the gallbladder and removal of the segment 4 and 5. Or otherwise you can say is removal of the liver with a 2 cm of the margin with bile duct resection and major hepatectomy as necessary. Now what if the disease, we have considered all management of all the steps like T1 stage, T2 stage, T3, T4 with N0, N1 staging. And what if the stage is M1 now? That is, the metastasis has occurred. Systemic chemotherapy then comes in the picture. And the current chemotherapy that is being used is a combination of gemcitabine and platinum-based chemotherapy are used. Second line therapy is capiri, that is capecitabine or irinotecan. In palliation, what you can do is for pain relief, analgesia can be given, opioids or non-opioids. For biliary obstruction, what you can do is ERCP or PTBD followed by self-expanding metallic stent. If there has been there has been infiltration into the duodenum or nodal compression leading to gastric outlet obstruction, what nasojejunal tubes or under fluoroscopy guidance or gastrojejunostomy may be considered. How do we follow up such patients? Follow up 3 monthly for first 2 years, followed by 6 monthly for 3 years, and then annually with CA99 levels and USG. CT or PET CT scan can be done if recurrence is suspected. Thank you so much.